just show you a few cases and we'll go straight to ACLS. I'll just show you a few cases. What can we see in this ECG? ECG cannot leave you, Abby. It's chasing you everywhere. You keep on running after me. Yes, what can we see on the ECG? Diagnosis. What's the main diagnosis here? What's the reading? Noshime, have you used rice to swallow the... What's the reading? Normal, right? Hello, P wave before every QRS. QRS after every P wave, yes. Upright in the 2 and upside down there, Abi. Okay, QRS is fine, but QRS is very long. Are there Q waves? Are there Q waves? That is after the P wave, a negative deflection, nothing else. Is there any Q wave you can see? Where? V1, V2, V3, V4, V5, V6. Very serious matter. What else? Is there ST elevation? Wow, I should have seen that one since lateral raw. ST elevation where? This is called tombstone kind of, it looks like a tombstone, square. And also the patient can die very quick. Okay, so we can see that one. You should never miss this one. You are the nurse on the ward, you did the ECG, you should not miss this. You should tell your doctor, doc, don't go for surgery. You won't come out. It's not benefit you. Lateral, Abi, perfect. So you can see this is quite extensive. All right, so what do we do now in this kind of case? Having chest pain, standard 5 to 10 minutes, get into that CardioCare hospital, ECG, troponin, all that algorithm we talked about. Then we get into the cath lab, and then we pass our wire straight. I have not slept actually. I left the hospital at 7 a.m. this morning because I had to do this over the night for an emergency. Then we look for the blockage, and then we do on the right and on the left. So can we see the blockage here? That is the left anterior descending. And we can see the blockage. Can we all see it? So we pass our wire and then do our bloom there. Very easy. Then we go with our stent. This is what we used to do the bloom, that thing we are turning. Okay, and then we can now put our stent in. That is how we are putting the stent. This is what it looked like before. And then we'll see what it looks like after we have put in the stent. And after we have put in the stent, chest pain is down, patient is much better, all those things start to change. Okay, very, very easy, Abi. Sharp. No cuts, just a needle stick, patient is awake, you know. A lot of things can go wrong, child. It's not easy like that. Okay, can we see this ECG? This was the referring ECG. Yes, what can we say? 51-year-old referred to CardioCare with breathlessness while they are preparing for ACLS. Where's my crash cart? And where's the laryngeal mask? Yes, what can we see? What's the rate? What's the rate? 300 divided by how many boxes? 300. What's the reading? There's nothing like regular. Is it sinus or not sinus? Sinus. PR is fine. QRS is not wide, Abi. Q wave. Where is Q wave? Is there Q wave there? Where? Some people are not even talking on your own seat or your own by yourself. Talk now. It helps you. It helps. So if you missed it, you will now say it. Nobody will know. V1, V2, V3, V4, V5, V4. V5, you can see there's a small notch. So it's not yet a Q wave. So it's no longer the first negative deflection. So 1 to 4. And there's SC elevation. Can we see the SC elevation? Or actually we can see V2, V3, V4, V5, V6. We can also see AVL, Abi, and 1. Beautiful. So by the time he got to our hospital, the ECG has started changing already. So it means the damage is already happening. Then we now come in, do the same kind of procedure. We either use the femoral or we use the radial. The one I did last night, I did radial. And you can see total occlusion of the proximal left anterior descending. 100% blockage. So there's no block. That's when you can see where this one is. That is what it was after. Okay, so that is a very straightforward case. Patient starts while you just open it up, patient starts feeling better. By the next morning, they are much better, they go home. Do you know what's happening? If you don't get the patient to do this procedure within 30 minutes, 1 hour, every minute, that part of the heart is dying. Is dying. So even if you open it later, sometimes there will be more problem, or that heart has already died. It's only the other ones that have not yet died you will save. That patient will still develop heart failure down the line. So that is why you must get them to the cath lab fast. And if you don't have a cath lab, we gave times, Abi. If you cannot get to a cath lab within 2 hours, give Tenecte place. Reach out to us or Alte place. Okay? Once we've given them, we normally use Alte place, we use Tenecte place, we have them. It's quite expensive, but it's very useful. It is cheaper than burial. So give it, then you cannot at all. Then give it, then it will open up at least some blood flow and save that myocardium. Sometimes, you know what, if you give that one, when you finally come for the angio, it will already be open. We will not do anything. Okay, so sometimes it's already open. Sometimes it may open just enough to get small blood flow enough to save that myocardium. So that's what we preach over Africa. Wherever you are, at least you'll be able to do that one before you can get them to have the definitive therapy, which is this. Now, if they don't have money, there are a lot of things that Dr. Adifila taught us about. 41-year-old, and the patients who have been doing are very young. 38, 41, 42, 35. Okay. Coronary angio, anterior stem, my ECG is not here. Patient came in, and then we did this. So this is a very interesting case, I remember, because they had to call me out. 100% occlusion. Can we see the 100% occlusion? Again, just like the previous one, something should have come across at that top. Can you see where that white line is? So that vessel is missing. So sometimes you must know what you are looking for, so that you know when it's not there. So what we did is we passed our wire across, called a BMW wire, not like the cow. And then we now dilate it to the balloon to see whether we can get some blood flow. We can see small blood flow coming up. Okay, so what do? It's not good enough. So next thing we now do, we now take what we call a clot extraction device. So we have an export aspiration device. We pass it into, there's a small dot, if you can see from back, small dot. Can you see a small dot moving back? So that is to get the clot out. This is the clot we aspirated from the LAD at the time. Okay? It's expanded, it's not as big as that because I expanded it. So now we can see blood flow. Can we see the blood vessel showing a little bit more? Before it was not showing at all. So now we're still not happy with this. We could get a better one. So what do we do next? We now take our stents, 3.5, 30 mm stent, and then we open up the area that is blocked with a stent. After we do the stent, sometimes the place is so used to that thing. So even after we do that, we still don't have a good enough blood flow. Distally, there's spasm. The vessel tightens up. So we have to do drugs that are involved in coronary physiology. So what do? We do what we POT of the stent, and then we give intracoronary adenosine. And you can see the blood vessel now. Can you see it? That thing was 100% occluded, not showing at all, and now we can see good blood flow down the line, and then that is a heart saved. So this is something that we can recognize, and we can reduce the incidence of sudden death. In patients that do not get coronary angiography and PCI revascularization therapy, 30%, over 35% risk of sudden death within 30 days of the heart attack. Now, those are those that survive. 1 in 2 will die before they get to the hospital within 1 hour. They just remote control from village, Abi. They swore for him. He fought with his neighbor, and it was neighbor that did him jazz, and he fell down, he died. You know, you've heard of those stories, Abi? Those are the 1 in 2. Bam, they will not make it. Of those that get to the hospital, those that do not get PCI, 1 in 3 will not make it if they don't get PCI. Okay, so it's very important in this. So sometimes we did it for renal artery. This was for a patient. We put a stent for him, 2 stents. Later he went back, he had a stroke. Somebody treated him. He went back. Then he came back with abdominal pain, severe. They did a CT for him because he's a senior doctor. Immediately they did a CT for him. Then they did CT angio. They could not see the kidney. So they rushed him in. He had to drive all the way here. Got here around midnight. Then we did what we call CDTT. And then we could restore the blood flow back to the left kidney. Went home 2 days after. We realized he had a thrombophilia. He had been on apixaban. We had to now change to warfarin. He was doing fine. After a while, I don't know, he started missing his drugs. He now got another one, got a stroke in his eyes. Eventually, one day I heard he passed on, unfortunately. But he had multiple massive thrombotic episodes. But in this case, this is a kidney saved. This is a kidney saved. That would have been a nephrectomy because that kidney will not get blood supply. Everything will die off to form a nidus for infection. Okay, and sometimes we have pulmonary embolism, massive pulmonary embolism. You can see that big clot there, not allowing blood to flow. And after we are done, we have that. So what do we do in this case? There are two options. One option is to try and do a clot extraction like we did the last time. Or the second option is to do a CDT, which is we go in, we try and break the clot mechanically, and then give slowly a thrombolytic agent that will now break up the clots and then allow good blood flow. That will reduce pulmonary hypertension significantly. Is this too much? Is this higher than you? No, but it's possible. We are doing this every day, just not far from here. And this is an IVC filter. We use it to prevent clots from going from the leg. So we put an IVC filter for her because she has had recurrent ones. You can see it looks like an APC broom, Abby. So by the time you put it in, there's a small hook at the top. When we want to remove it, we typically will come from the jugular, go down, and then take that hook, put it inside a snare, and then pull it up and bring it out from the top. Okay? Looks nice, Abby. It looks cool. It's like plumbing. Okay, I think physiologist Sharon showed us this, Abby, where we have anterior tibial artery occlusion, we put a stent, and this was the before leg. Normally, before when I was in medical school, this leg goes off. This is an amputation. But now you can see, by the time you get that blood supply going, it heals. Sometimes we just cut off one toe and then fix it. It's better than losing the whole leg. So those are things that can be done in interventional cardiology. There's this patient, I will take this as maybe last case. He had bleeding from a teaching hospital. They were trying to do a femoral cannulation and somehow they punctured the femoral artery. So he was bleeding there and Jehovah's Witness. PCV was 12%. So CTSU refused. So you can see the blood flow before, Abby, shooting out. Then we put a cover stent. That's before, that's after. So put a cover stent to stop the leakage from there. PCV remained 12%. We referred him back to where he came from. I don't know if he made it. All right, so those are some cases and then devices. Dr. Dafe has talked about quite a number of them. And I think I will stop here about that in that regard.